We talked a bit about kind of the novelty of this new class of agents, Pomoras, and how effective they are. And let's talk a little bit about kind of where things still need to go and kind of the gaps in care. Teresa, you alluded to education. What would you identify just broadly as some of the unmet need in this area?
So I think something that we've already talked about is the differentiation, not only being able to make the diagnosis about opiate-induced constipation, whatever tools that you're going to use, being comfortable having that dialogue with your patient, but differentiating between OIC and idiopathic constipation. And if they're conjoined, if they're presenting together, then being able to treat, cojoined. And then being able to not only educate your patients, but educate your peers. So really important for peer-to-peer education about making the diagnosis and appropriate treatment. The guidelines that are out there, even if they're not the best guidelines, and what new organizations like AAPM are recommending. Early recognition, so preemptive treatment, and then early recognition in terms of failures in treatment.
I think education, too, is so important when giving a Pomora, because what are they used to doing with their over-the-counters? If one didn't work, two's better. Two didn't work, double it up, And so oftentimes they think, well, same situation here. If we don't educate appropriately, then we very likely could have problems, and we know that there could be, overexposure of one of these products, and it could cause it to cross blood-brain barrier and potentially lower the analgesic effect and offset those opioids there. So education is clearly needed when you are putting a patient on a new class of drugs such as this, because they're used to handling these type of medications differently.
And of course, another issue is, especially with a push to take people off of opioids, think about a patient that's on chronic pain. They haven't made lifestyle changes, and now they made a commitment to do that, and they come off of the opioids. They've been on massive amounts of OTCs, and now they're dependent on them without an opioid. That's another issue that needs to be considered.
Another one on education. I think you're right, Brett, about certainly you should never double these, and I think patients don't always think that one's good, two's got to be better, but they get in trouble that way. The other thing is sometimes when they choose to take a PRN, and because we know one of the things that happens with initiation of the drugs is they can get abdominal pain. And I tell patients, I like to tell them about that. I find that if you warn patients about side effects of a drug, they're much more likely to be tolerant to it, or they understand then. And you say, look, when you first start this, we think you're waking the gut up and you may get some abdominal pain. The risk is if they take it PRN every third or fourth day when they really think they need to have a bowel movement, they can really tend to expose themselves to a lot more side effects, particularly abdominal pain, cramping with it, versus if they take it on a daily basis as these drugs are indicated for.
Yeah, and that is incredibly important point, and for pharmacists as well. They do a great job about looking at drug-to-drug interactions and some of these other factors that we had talked about. But if you can normalize and let the patient know what they're going to expect, they're going to be a lot more compliant. Yeah.
Steve, what are your thoughts on where the field of opiate-induced constipation management is evolving?
Okay, I'm going to go all the way back to the start. We're looking at alternative to opiates. That whole sphere is expanding. And so that may be part of that. That said, we are here really talking about people that have found a way to move on with their life by the use of opiates. And so I think, you get back to education, what we're probably going to see the field evolve with is educating more of the providers to expand who might be patients that would benefit from this. Most of us we didn't have this in our toolbox a decade ago. Now, providers need to make sure that it's in their toolbox, and it's not just for palliative pain patients. It may also be for patients with the chronic pain, that it's not just, you said it brilliantly, take less opiates. It's let's find a solution and wake them up to the fact that this is actually a drug that acts at the site of the problem to reverse that problem. If you put it to providers that way, it's great. But not just expanding who's going to benefit from these and who's going to possibly prescribe them more often, but I actually have to say I'm going to spend one more minute going back to the opiate use disorder. A lot of those patients present to us with abdominal pain, and they don't tell you that their prescription monitoring thing says, I'm on an opiate. but they're using an opiate every day. And so starting that conversation with them, and get back to the fact that the first solution to them is to get off their addiction, find other options for them, et cetera. But if you don't treat the problem they came for, a lot of them will dismiss the medical practice as being a solution. And what we want to do is open the doors, say yes, we're here to help. And I think that's part of where the field's evolving. Plus, I'm thrilled to hear what the next mu receptor antagonist is going to be that's out there, because this is clearly an area that needs to be expanded.
Well, I think one of the things, just speaking in the broader sense, this idea that we can get so specific in our treatments, in our development of different pharmaceutical agents, and have as few systemic side effects as possible is just amazing. And I think that's where we're going in medicine and drug development in general.
Well, you know, that makes pharmacists and industry and medicinal chemists
Indispensable.
Right, indispensable, no pun intended. Because really, it's you know, from a chemical standpoint, at least to me, it doesn't seem that difficult. You know, you pegylate a chain, or you do something to prevent the passage because of P-glycoprotein through the blood-brain barrier. But we, of course, do need to remember that there are people that may be prone to blood-brain barrier issues. You know, people with Alzheimer's, traumatic brain injury or something like that, seizure disorders. So we have to be careful about that. But I agree. I mean, it's pretty cool that we're able to manipulate the chemicals in the way that we are, which kind of leads me to another thing, like where are we going with this, right? So the next group of drugs I think that are coming out are the serotonin type 4 drugs. And in Europe, there's actually one called tagarsad, and it's being, I think it's in phase 3 studies in this country now. And again, you know, it's activities on serotonin. And there are other drugs too that kind of look at peristalsis. Some of you guys may remember from years ago, there was a drug called cisapride, right? And it increased peristalsis, and that was a great drug. But there's a lot of drug interactions, so it came off the market. And now, of course, we have metoclopramide. We've had that, but the problem with that is that there's dopamine, CNS dopamine problems. So there are a bunch of drugs that are looking at increasing peristalsis that are coming down the pipeline as well.